do type 2 diabetes mellitus. So if you look at the diabetes, I'll be taking the form of question and trying to answer those questions. So just to understand diabetes, what are the diagnostic criteria for diabetes mellitus? And if you look at this slide, it gives you diagnostic criteria for diabetes based on glucose. So here you have the fasting plasma glucose, and the third column gives you the results after 75 gram glucose is given, and 2-hour value is given there. And you can see diabetes is diagnosed if the fasting plasma glucose is more than 126, or if the 75 gram OGTT gives you a 2-hour value more than 200. Also, a casual, a random glucose more than 200 in the presence of symptoms is good enough to diagnose diabetes. So we normally would say, since it's a lifetime diagnosis, that if these values exceed these categories, if there are osmotic symptoms, clear-cut symptoms of diabetes, then we will diagnose it based on single value, even a casual of more than 200. But if there are no symptoms and the patient is just done a routine test and has found the glucose values higher than the threshold, then we would do a repeat test. You can also see the normal values less than 109 of fasting plasma glucose. As you know, ADA, American Diabetes Association, revised this down to 100. Most labs still give you 109, and 140 at OGTT as and below as normal. And in between is called the impaired fasting glucose, if the glucose is between 110 to 125. And if the glucose at 2-hour value is 140 to 200, then it is impaired glucose tolerance. We also have HbA1c targets or diagnostic criteria. HbA1c more than 6.5 is diagnostic of diabetes, single value, and less than 5.7 is normal, and in between is at risk of diabetes. So moving on to my second question. How many types of diabetes are there in the World Health Organization classification? So if we look at them here, we spoke about type 1 last time, type 2 today, but we need to remember that there are other specific types. We don't call them type 3, but we just label them as other specific types. Those are those that result from something underlying. Say, for example, some children could be born with monogenic diabetes. There is a single mutation in and that leads to hyperglycemia. There are some people who have an endocrine disorder like acromegaly, Cushing's, pancreatitis that has led to beta cell failure, pancreas removal due to a surgery, and so on. That can lead to diabetes. Steroid treatment can lead to diabetes. All of that comes under other specific types. There are also hypothalamic disorders like Lawrence-Moon-Beadle syndrome, etc., that will give you diabetes, and we don't call them type 1, type 2, whatever the treatment, we call them by their specific type. So as you can see, the diagnosis is now based on etiology. Type 1 is beta cell failure, type 2 is insulin resistance and insulin deficiency. Other specific types are due to a specific problem, genetic defect, polymorphic genetic tendencies, hypothalamic disorder, endocrine disorder, and so on. And then we have diabetes diagnosed in gestational period, called the gestational diabetes. So as you can see, there are 4 types of diabetes that are clearly distinguishable usually. Whatever the type of diabetes, we diagnose them usually based on glucose, and that is why we talk a lot about glucose and its control. So you can see here, normoglycemia to hyperglycemia is a tendency, is a transition from one to the other that happens. So patients will be normal first, sometimes with antibodies and type 1 diabetes, but normal glucose, move on to pre-diabetes or impaired glucose tolerance or impaired fasting glucose. then non-insulin requiring diabetes, insulin requiring diabetes, and insulin requiring for survival. So type 1 will do that pretty rapidly. Type 2 and other specific types may transition more slowly. So here I have 5 types of patients. Which ones have type 1 diabetes? So here is a 65-year-old, GAD antibody positive, C-peptide low, no ketosis. Does this patient have type 1 diabetes? Yes. Although there is no ketosis, we know that autoimmune antibodies are positive and the insulin production is low based on C-peptide. So this patient does have type 1 diabetes. 8-year-old child who presents with ketoacidosis is clearly type 1 diabetes and the typical type 1 diabetes. 1-month-old child presenting with diabetes, but the GAD antibody is negative, but the C-peptide is low. So we have insulinopenia, but no autoimmunity. 1-month-old child. What does this child have? This child in the classification has other specific types, which are in this child is most likely due to a monogenic defect in the genes. So we call it MODY, monogenic diabetes here. 30-year-old diabetes developing after pancreatectomy has clearly in the previous chart other specific type of diabetes. So we will label this patient diabetes due to pancreatectomy. 56-year-old treated with oral drugs for 10 years, now requiring insulin. Is this patient type 1 because now the treatment is insulin? No, this person had type 2 diabetes because this person was clearly surviving on oral drugs for 10 years, now has developed insulinopenia. So actually, if you measure C-peptide in this patient, it will be low and insulin is now required for control. So this is type 2 diabetes that is now not responding to oral therapy because of insulinopenia. So just one more slide to talk about type 1 versus type 2. You can see that type 1 is very uncommon. As I said last time also, type 2 is pretty common. Most of the diabetes we will see is type 2. Doesn't mean that other types don't exist. So type 2 is usually an older person. Peak age is about 60 years, but it can develop in children who are obese and are insulin resistant and can occur very commonly in adolescents nowadays and can occur in young adults. But over time, as the age advances, the risk of type 2 diabetes increases. It starts subacutely as opposed to type 1, which is a disease of younger people. But as I showed you in my MCQ previously, it can also occur in older adults. It is usually acute onset, but sometimes could be missed by even 1 year by oral therapies. Symptoms are very prominent in type 1, whereas in type 2, it is very variable. Some of them will present to you with acute hyperglycemia, but normally most of them are found asymptomatic on routine screening. Type 1, because of the lack of insulin, will be lean, and in type 2, because they are insulin resistant, and that is one of the key pathogenesis of these patients, will be obese. Now, Asians may not be very obese, but will have central obesity. So we call them metabolically obese, and they may have other features of metabolic syndrome, like high triglyceride, low HDL, and insulin resistance if you check their insulin sensitivity patterns. In type 1, there will be autoimmune markers, GAD antibody and ICA, insulin islet cell antibodies. And in type 2, there will be other comorbidities because of the underlying nature of the pathogenesis. Because they are obese or centrally obese, they will have other comorbidities. Hypertension, dyslipidemia are common. Some of them are diagnosed when they have already had a major coronary artery disease like MI, and then subsequently diagnosed to have type 2 as the underlying condition. They normally, type 2 will respond to insulin or oral hyperglycemic agents. In type 1, though, they are insulin deficient and therefore will require insulin for survival. Otherwise, as I showed you last time, you may remember about 100 years ago, the result of type 1 diabetes was, the end result was death, because there was no therapy before insulin was discovered. If you check the C-peptide, it will be low in type 1. Sometimes we give glucagon and then check the C-peptide. Glucagon will elevate the insulin production, and C-peptide being low to glucagon is also a marker of type 1 diabetes. All right, so having spoken about the various types of diabetes and particularly how to distinguish type 1 to type 2, now I'm going to move on to the therapeutics proper of type 2 diabetes. So the question is, what are the glucose lowering agents? So if you look at the etiopathogenesis of type hyperglycemia in diabetes, you can see there are multiple problems. In the olden days, we knew about insulin resistance and decreasing insulin production, insulinopenia. And you can also see the agents that work in those parameters. So insulin resistance can be countered by metformin or thiazolidinediones. Also, you can see increasing hepatic glucose production, which is the reason why type 2 diabetes patients have hyperglycemia in the morning. And that is also similar therapy can target that. Sensitizers, we call them metformin and the glitazone, so thiazolidinediones. Then you have insulinopenia, which can either be treated with, replaced with insulin, or insulin secretagogues, sulfonylurea or glycinides as we call them. We also have glucagon production, which is high. We still don't have a proper therapy for that, but if possible, antagonist to glucagon may work theoretically, but we still don't have them. Increasing in renal glucose reabsorption is a problem in type 2 diabetes, and SGLT2 inhibitors are therapies targeting that. Deranged adipose tissue metabolism along with insulin resistance is there, and thiazolidinediones are the only drugs that target that. Then we have central problems. In the brain, we have central appetite dysregulation, and from the gut, decrease in incretin effect. For that, we use GLP-1 receptor agonists and DPP-IV inhibitors, which increase the GLP that is naturally occurring. Central appetite dysregulation or high appetite is a feature of type 2 diabetes, and GLP-1 receptor agonists will work on that. Then we have the gut, increasing glucose reabsorption, and the role of gut microbiota is also being spoken about now. And alpha glucosylase inhibitors decrease the glucose absorption from the gut. SGLT2 inhibitors, some of them now we don't have them, but in trial, SGLT2 inhibitors that impair the glucose reabsorption are there. So if you look at guidelines, you will see that lifestyle changes such as healthy eating, weight control, if they are overweight, weight control and weight loss. If they are underweight, increasing the calories, increasing physical activity, and educating patient to be self-aware of the behavioral changes, as well as being able to adjust the drugs is important, and we do diabetes education for that. So lifestyle changes are the first and foremost step in the control of diabetes. And you can see along with lifestyle changes, on diagnosis of diabetes, metformin is recommended as monotherapy in the guidelines. If the patient doesn't control within 3 months, then we move on to dual therapy, which can be metformin plus any drug that has been listed in the previous slide. But we will individualize therapy based on what kind of patient we are speaking about. I will talk about it in another slide on how to individualize. If two drugs don't work, we can go to triple therapy, basically using 3 oral agents or 2 oral agents plus insulin is possible. If none of these therapies work, we move on to metformin plus insulin, either basal insulin or mealtime insulin plus basal insulin or GLP-1 receptor agonist plus insulin are possible. So these are multiple options that are available. Normally, we will base therapy based on patient's weight, patient's other comorbidities, such as whether the patient has renal disease or cardiovascular disease, whether the patient is underweight or overweight, will be how this therapy is decided. So normally patients have to move from one therapy to the other based on where they are at each time. And we need to get glucose rapidly controlled by combining or using monotherapy. So now I'll go on to talk about these few agents that we've spoken about in the previous slides. So now I'm going to talk about GLP-1 receptor analogs or agonists. So when food is consumed in the ileum, GLP-1 is produced by the C cells of the ileum. The GLP-1, normally glucagon-like peptide, acts in 3 different sites. In the brain, it decreases appetite. In the pancreas, it does 2 things. It stimulates insulin production and cuts down the glucagon secretion. So as you remember, insulin lowers glucose, glucagon antagonizes that. So it cuts down glucagon production. And in the stomach, it slows down gastric emptying. What is the end result? Somebody who has loss of appetite and feels full, sometimes nauseous because the stomach is always full, and has high insulin and lower glucagon. And as you can imagine, this reduces glucose, and cuts down the weight by satiation response, as we call it. So GLP is a drug that will do 2 things. By replacing GLP, you can reduce glucose as well as cut down the appetite and the weight. So not just these few, weight loss and glucose control, they also have other benefits, as you can see. Renal benefits. In CKD, it is shown that using GLP-1 receptor agonist decreases renal function deterioration. Lipid levels are also decreased. Blood pressure is decreased. As a result, you have less myocardial infarction with these agents. So you can see there are multiple types of GLP-1 receptor agonists. There are short-acting drugs, long-acting drugs. So in the short-acting, we first had exenatide, which had to be given twice a day, and then lixisenatide, which is given once a day, and long-acting drug, liraglutide, which is given once a day. And then once a week, drugs are now available, exenatide's slow-release form, and then few varieties, albiglutide, dulaglutide, and semaglutide are all agents that will now be possible as a weekly injection. The only problem with these agents is that they are very expensive because they are new agents. And because they are all proteins that actually mimic the GLP hormone that is produced by the body, it has to be given as an injection. And the newer types of injections are like that, where even the needle is not visible. So as I said, these are the multiple factors we will use in treating diabetes. What is the weight? What is the target HbA1c we need to gain? What about the efficacy of the drug? Cost is a major factor, as I said earlier. Hypoglycemia risk. is hypoglycemia risk is high in some people. So in such people, avoiding hypoglycemia is a major factor that we need to take into consideration before therapy is started. And then we have to think about comorbidities. Is there coronary artery disease? Is there renal disease? Are two questions that we always ask before we start therapy. So I'm going to go past that slide of GLP-1 receptor agonist and move to the second new class of agent, SGLT2 inhibitors. So normally, this is a picture of the renal tubule and the afferent and the efferent, and you can see that the glomerulus from the in the glomerulus, their glucose is filtered out into the renal tubule and would normally be lost in the urine. So despite hyperglycemia, the SGLT2, sodium glucose ligand transporter 2, there is also a 1, SGLT1, but the SGLT2 is the predominant one which reabsorbs 90% of the glucose. Even when the glucose is high in the blood, the SGLT will absorb most of the glucose that is filtered. So while you have a waste product that is damaging the body, your body actually reabsorbs the same glucose molecule, resulting in hyperglycemia. So if you can block that mechanism by using SGLT2 inhibitor, you can block that and cause at least 50% of the glucose that is consumed or filtered in the renal tubule to be excreted in the urine. So you are causing glycosuria by that action. There are at least 3 medicines that are available since 2013: canagliflozin, dapagliflozin, and empagliflozin. All 3 drugs are available in this country. And because you have glucose excretion in the urine, you can also imagine when the glucose goes, there is an osmotic threshold. So water is also lost more. And this also causes sodium to be excreted down the renal tubule. So you have sodium, water, and glucose to be excreted. So what is happening? Calories are being wasted in the form of glucose. And then you have sodium loss, which, as you know, will result in blood pressure lowering. So once again, you can see that these new agents doesn't just cause weight loss because of glucose prevention of glucose resorption and glucose excretion. It also causes blood pressure reduction. There is some lipid improvement, and because the intratubular sodium is low because it's being lost, there are renal benefits as well. Not just sodium, stuff like uric acid are also lost, and this results in renal benefits to the patient. And because there is blood pressure reduction and lipid improvement and weight loss, cardiovascular safety has been shown. So now my third group of agents that I want to show is one of the very old drugs, actually the very first diabetes agents are from sulfonylureas. So if you look at the beta cell, you can see there are 2 mechanisms that control the insulin granules or the insulin containing vesicles, which have to be excreted out. Extravasation of that vesicle has to happen. For that to happen, we have a sodium-potassium pump, which keeps potassium in and sodium out. And this other KIR 6.2 or sulfonylurea receptor, which sends the potassium out again. And then you have the calcium channel, which allows the calcium to enter. So for insulin to be excreted, you need potassium pumped out of the potassium channel, and that causes the calcium to open and calcium channels to close as a result. the polarization is maintained and insulin containing vesicles remain intracellular. If you can close that with the sulfonylurea drug or non-sulfonylurea drugs, which I mentioned as glinides, you don't excrete the sodium. So you don't excrete the potassium is not pumped out. Sodium comes in, resulting in depolarization, opening of the calcium channel. And when the intracellular calcium channel levels is increased, you have exocytosis of the insulin from the intracellular. So sulfonylurea binds to the potassium channel, or the KIR 6.2 channel, potassium channel is where they act. So when they bind, the potassium channel is closed and insulin is extravasated. So the insulin level goes up. So in a patient who has beta cell function, whose beta cell function is low and has insulinopenia, you can increase insulin production by giving sulfonylureas, which will act in this way to increase insulin production. So the only difference between the many drugs in that class is their duration of action. As you can see, you also have older drugs, tolbutamide and chlorpropamide, which were fairly long acting. And then now we don't use them much. So you can concentrate on the more moderner types or newer types of sulfonylureas. Among them, you can see glibenclamide and glimepiride and modified release gliclazide have half-life as long as a day. Gliclazide is shorter acting and about 8 hours of action. So that's the only primary difference between their various drugs. Glibenclamide, glimepiride, and the modified release gliclazide are long acting, whereas standard gliclazide is short acting. We now move on to the fourth drug, which is the metformin. So if you look at the energy metabolism of the body, you can see that at the liver and muscle, you need AMPK, adenosine monophosphate activated protein kinase, which is like the molecular driver of metabolic functions in the body. So if the primary action of metformin is to increase AMPK production from liver and muscles, also in the brain if you look at that. So as a result, you can see the end result is insulin sensitization in the liver and in the muscles, which result in glucose uptake. So it doesn't deal with insulin production, but these drugs are sensitizers. They make the insulin resistance in the liver go down and the peripheral tissues go down, resulting in increasing hepatic insulin sensitivity and increasing glucose. And as I said, fasting glucose is high in patients with diabetes because of the gluconeogenesis, and metformin will sort that out. So the fasting glucose can be cut down as a result. That was a simplified version of metformin, but if you actually look at metformin, what we are learning now is that it has multiple effects, not just in the liver, but also in the gut. It changes the microbiome in it also increases glucose utilization in the gut, and it increases the enterohepatic circulation of several bile substances, etc., which result in delayed absorption of the glucose. So you can see there are multiple benefits of metformin. Even the loss of appetite that patients have and the metallic taste that they get is an active effect of the metformin in the oral cavity. So if you look at metformin and why that is number one drug for most patients, despite being an older drug, you can see that in the major study called the United Kingdom Prospective Diabetes Study, metformin resulted in lowering of most of the diabetes related endpoints, including death rate by 36%, myocardial infarction by 39%, stroke by 41%, microvascular disease by 29%, related 42%, and any diabetes related endpoint by 32% during the study period of 10 to 15 years. And then 10 years later, that is 25 years from randomization, if you look, obese people who were given metformin still benefited from original metformin exposure. And this is one of the drugs that can target microvascular complications as well as macrovascular complications of diabetes. So that is why metformin is still number one choice despite many of the new drugs being available. So we now go to a little bit of a non-fashionable old drug called Acrobose. Do you know which enzyme is blocked by Acrobose? So normally if you look at the gut, carbohydrate absorption happens pretty quickly. When you take Acrobose, the glucose absorption is delayed and in the terminal ileum rather than in the duodenum where most of the carbohydrate is absorbed. How does that happen? It is because the alpha glucosidase, which breaks down disaccharides into monosaccharides, is blocked by drugs like Acrobose. So that results in more delayed absorption. So you can see here without Acrobose, rapid glucose absorption. With Acrobose, more blunted and longer time absorption, resulting in postprandial hyperglycemia being lowered. And also the body is able to handle this glucose entry better than if it were to happen much rapidly. I spoke about thiazolidinediones in my earlier, in an initial slide, and you can see how they work in the liver, muscle, and adipose tissue due to the PPAR gamma, peroxisome proliferated activated receptor gamma activation results in improving insulin sensitivity. And you can see here decreasing in inflammation in the tissues, particularly from the adipose tissue. So here is a group of drugs, thiazolidinediones, which result in insulin sensitivity. Now we move on from the different types of diabetes controlling agents or glucose lowering agents, as we call them, to significant complication diabetes. What percentage of patients of diabetes will die of cardiovascular disease? So as you know, diabetes results in a constellation of complications. It can result in cardiovascular disease. It is associated with hypertension, dyslipidemia, and peripheral vascular disease. It can result in neuropathy both peripherally and in the autonomic system and in the stomach. It can result in retinopathy and macular edema and lead to blindness. It can cause renal disease. It can cause erectile dysfunction. But cardiovascular disease is the number one complication of diabetes. So if you look at causes of deaths in diabetes, you can see that ischemic heart disease is found in about 40+% of patients. And if you combine the other CVD and hypertensive heart disease put together, you can see that most of the deaths, 2/3 of the deaths in diabetic patients occur from cardiovascular disease. Hafner's study in 1998 also showed when he looked at CV mortality, cardiovascular mortality percentages here in those who did not have prior MI and those who had prior MI. We know if they are non-diabetic, the risk of dying from an MI is 8 times high in those who had a prior myocardial infarction. If you look at diabetics, their risk of dying without an MI was equal to those who had no diabetes but a prior myocardial infarction. So Hafner called diabetes a cardiovascular equivalent. That is, it's like having had an MI at diagnosis of diabetes. And then you can see those with diabetes and a prime MI, the cardiovascular mortality is much higher than the standard. So here we call it a cardiovascular disease equivalent or a major risk factor for cardiovascular disease. So the pictures you see are Oxford University, which ran the United Kingdom prospective diabetes study. One of the slides I have shown you already for metformin. So what they did was they showed that if you had tightly controlled blood pressure, the risk of almost every diabetes related complication, including death or any endpoint, stroke, retinopathy, heart failure, could be massively decreased. So about 20 to 50% decrease in these complications just by giving them captopril and atenolol as the high blood pressure medications to keep their blood pressure about 130/80. They also showed that compared to traditional control, tight glucose control with an aim of HbA1c 7 resulted in 25% reduction of microvascular endpoints and myocardial infarction reduction by 16%. And when they looked at it later, early control resulted in long-standing benefits. And at the beginning, if the patients were not controlled well, they were having higher complication even over long time, like 25 to 30 years. So how we treat diabetes now is that there are two types of complications: microvascular complications, which are primarily targeted by glucose control, and macrovascular complications, which are targeted by not just glucose control is not enough, dyslipidemia treatment, controlling insulin resistance by weight control, hyperinsulinemia by weight control, reduction in inflammation by weight control, etc. can be done. So we now have multiple therapies targets. So we have A, B, C of diabetes, A1C reduction or glucose reduction, blood pressure and cholesterol reduction. All three together will give you major reduction in complications, but weight control is another important thing we will do. So here you see the current targets for glucose control in type 2 diabetes mellitus. HbA1c lower than 7. And for that, you need to keep glucose always less than, this is not fasting, pre-prandial, that is before lunch, before breakfast, before dinner. This doesn't have to be fasting. The glucose levels that you see before meal less than 130, and the peak postprandial glucose less than 180. That is, peak means even at 1 or 2 hours you can't see more than 180. That will give you an HbA1c less than 7. And a blood pressure less than 130/80 is the other three targets we go for in addition to the weight. So there are Sri Lankan guidelines as well, which have been, which are being updated now, but this is the last one that we have published. And you can see this is from the Sri Lankan guidelines. Lifestyle modification and health education for all patients with diabetes. First line monotherapy of metformin unless it is contraindicated. If the initial entry glucose is high, you could start with 2 drugs immediately. And if the glucose is very high, use insulin. And if the glucose is not controlled, you start a second agent. In Sri Lanka, we say sulfonylureas are the preferred second choice because of the cost, but any of these agents can be used, including basal insulin. Adding a third agent. If 2 drugs didn't work, you can add the third agent. If 3 drugs don't work, you could go to single dose insulin or multiple daily dose insulin therapy. HbA1c target of 7 is what we want to target, but you can have more stringent targets to get better results in those who have new diabetes, those who are younger, A patient who is well motivated to have near normal glucose, and patients with no other comorbidities. We have a less stringent control of up to 7 to 8 for those who are elderly and those who have multiple complications and multiple comorbidities. So we would start therapy based on initial glycemia. We start with metformin plus or minus others based on initial metformin alone. And when the glucose is more than 200 or the A1C more than 8, you will start with metformin plus 1 or 2 more agents. If the A1C is more than 9 or 10 and the glucose is more than 300, you would start with insulin plus oral agents. We will choose drug based on the characteristics of the patient and the agent, and we need to get to target within 3 to 6 months of diagnosis and maintain it there. So once again, another chart that has been published by AAC, American College of Endocrinologists, that shows lifestyle therapy plus monotherapy based on entry glucose. If the entry glucose was moderately high, metformin plus one of the other agents. If the entry glucose was more than 9% or the fasting glucose more than 300, then we use insulin plus oral agents, particularly if there are symptoms. Otherwise, 3 oral agents if the glucose was very high at diagnosis. And whatever you do, you need to get to target within 3 to 6 months of diabetes. So minor hyperglycemia, 1 agent; moderate hyperglycemia, 2 agent; symptomatic or severe hyperglycemia, insulin plus other drugs. If there was CVD, you will need to start an agent that will control not just glucose, but will give you cardiovascular benefits. What are those drugs? SGLT2 inhibitors or GLP-1 receptor agonists. So you can see here EMPA-REG study results where empagliflozin compared to placebo decreased the myocardial infarction to by 14% here, and you can see that major reduction. This was the first time an oral hypoglycemic agent was shown to decrease cardiovascular events in a diabetes patient. And you can see similar graph, 13% reduction in myocardial infarction from GLP-1 receptor agonist, liraglutide. So if there is CVD, in addition to just thinking about diabetes control, we will think of agents that will also control and decrease future MI. And once again, canagliflozin, which is an SGLT2 inhibitor. So if in addition to thinking about glucose level, you think about CVD as a major problem, and if the CVD is there, then you start drug with empagliflozin, liraglutide or canagliflozin as one of the agents in place. If there was no CVD, then avoidance of hyperglycemia is the other thing that we will consider. If so, the agent of choice will be a DPP-IV inhibitor along with metformin, GLP-1 receptor agonist, or an SGLT2 inhibitor. So now metformin, DPP-IV, GLP-1, and SGLT2, these 4 classes do not cause hypoglycemia on their own. So what are the 2 agents that will cause hypoglycemia? Insulin, obviously, and sulfonylurea, which will increase insulin. So if you don't use any of those agents, you don't get hypoglycemia. So you can run an HbA1c as low as 6% without hypoglycemia, without much monitoring, because one of these, so you have 4 groups, metformin, DPP-IV, GLP-1, and SGLT2 will give you absolutely fine control without hypoglycemia. Now, what are the other things we need to think about? If there was albuminuria or decrease in EGFR and renal disease, we need to think about that. If the patient was planning pregnancy, then insulin will be required. Then patient preference and cost and coverage are also important. Here you see the various drugs that are given here: GLP-1, SGLT2, DPP-IV, insulin, thiazolidine, etc. Effect on CVD outcomes. The GLP-1 receptor agonist and SGLT2 inhibitors are superior to other agents because they give you reduction. Hypoglycemia, insulin and sulfonylureas give you hypo. The others do not cause hypoglycemia. Weight. GLP-1 receptor and SGLT2 inhibitor results in weight loss, whereas insulin, thiazolidines, and to some extent secretagogues, the sulfonylureas, will give you weight gain. What about the efficacy of decreasing glucose? Insulin is the most powerful. Next to that, we have sulfonylureas, SGLT2 inhibitors, and GLP-1 receptor agonist and DPP-IV, all of them almost equally effective. So if the patient is not responding to oral therapies like what we have used, then you use an insulin therapy, which we have spoken about earlier. Now here you have GFR of the patient. At the top you can see CKD1, CKD3A, 3B, 4, and 5 based on the GFR. And you can see that when it's red, some of these drugs have to be stopped. So metformin dose reduction at GFR of 45 and stop at GFR 30. Most of the agents have to be stopped at 30. Some of the drugs can be continued, for example, liraglutide, dulaglutide, linagliptin, which is a DPP-IV inhibitor, can be carried on in end-stage renal failure. But otherwise, most of the orals have to be stopped at GFR of 30, and you need to replace that therapy with insulin. So if type 2 diabetes was all about insulin resistance, why do patients require insulin therapy in type 2 diabetes is the last question I want to ask. So in type 1, there is an immediate need for insulin for survival, whereas in type 2, there is a downward slope. Or at diagnosis of diabetes, most people have 50% beta cell function, and thereafter it keeps declining, and that is why you need to start insulin, because there is insulinopenia. Initially, lifestyle will work with metformin and other agents. Later, you will keep adding other agents, and later insulin is required for survival. So type 2 diabetes is a progressive disease. It starts with prediabetes. You can start with one glucose lowering drug, then 2, then 3, and then insulin as the duration increases. So these are the indications for insulin therapy in type 2 diabetes. If the patient has significant hyperglycemia at presentation. So we said HbA1c more than 9 or glucose more than 300 will usually require insulin at the onset. Hyperglycemia not getting controlled with oral agents. Decompensation, surgery, pre-pregnancy will require, renal disease, I told you, will require insulin therapy. And any allergy or serious reaction to oral agents will also require going on to insulin therapy. So I don't need to do this again, but you remember bolus therapy and basal therapy. And you can use either human basal, or you can use analog basal like glargine or determa insulin. You can use human insulin boluses along with analog insulin boluses. or you can use pre-mixed insulin twice a day, analog pre-mixed insulin twice a day, which are both of the pre-mixed options, as you can see, leave the lunchtime uncovered. So there are multiple types of insulin. You can start with the basal and you can keep increasing. You can see the various types of insulins that we discussed that day, and you start, choose the insulin type, choose the dose, choose and other supplies, pen needles if using a pen, how much of that to be given. So this is the type of prescription that has to be done. So you decide on the insulin, whether basal, prandial, or premix, and then you give a pen device that is appropriate to the patient, or a needle in the government sector here, other supplies to be given. And so that's how we generate a prescription for patients. Which I spoke about. So I think I've covered the insulin types and how to use it. I've spoken about the different types of diabetes and diagnostic criteria, the various types of diabetes and how they progress. And then I spoke about the different types, classes of agents, metformin as the #1 choice. And then we spoke about the GLP-1 receptor agonist, and then we spoke about the SGLT2 inhibitors, and then sulfonylureas and how they increase insulin production, and as the AMPK manufacturing agent and its major reduction in almost all the complications in patients. We spoke about Acrobose on how it inhibits the alpha-glucosidase inhibitors. Spoke a little bit about thiazolidinedione. We spoke about the multiple complications of diabetes and cardiovascular disease as the #1 complication, diabetes as the CHD equivalent, and multifactorial control, blood pressure reduction and its benefits. We spoke about the UKPDS study and reduction in microvascular complication with glucose control. And I spoke about the ABC, the need for micro and macrovascular complication to be controlled. We spoke about the targets in diabetes, and then how to achieve them. Monotherapy, dual therapy, triple therapy, insulin therapy, and how to start it. And most importantly, 3 to 6 months is the time given to us to control it. We also said comorbidities like CVD will decide whether we are going to use an agent or not. If there is CKD, there are contraindications to drug and their doses. And then we spoke about insulin being required in type 2 diabetes because of progressive beta cell function, and then indications for insulin therapy. And then lastly, I showed you how to start insulin based on last time's lecture and this time's lecture. And I have just 5 minutes for you to ask any questions. Are there any questions, or is everything clear? All of you are muted, so unless you unmute yourself, you won't be able to ask a question. Yeah, go ahead. Go ahead. I can hear you. Go ahead. Isuri, is it?
So why always insulin is started after the oral hypoglycemic agents have failed? Is there a particular disadvantage if it is started much earlier after the dietary management fails?
Well, excellent question. That had been tried before. So the only problem with insulin is that it has two disadvantages. One is that it has to be given as an injection. So if oral insulin is available, perhaps we wouldn't be having this lecture. We'll just be saying give insulin in addition to the other agents like that. So if the patient is willing, you could still give the patients insulin. The second question is, are the patients going to do better if you gave insulin from the beginning is your question, I think. So this has been asked in some studies, like there was a China diabetes prevention study which had looked at young, when I say young, early diabetes, at the onset of diabetes, they gave insulin, and they showed that their pancreatic beta cell recovery was faster and it remained much higher if they had been given insulin early. So one benefit of giving insulin is that you are preserving beta cells, but at the cost of an injection. So you know that injections are not very well preferred by most patients. So if the patient is willing and the patient is motivated to try insulin, it can be given. There are no other benefits of insulin. It'll smoothen out your control and you can control the diabetes well. But the other oral agents, as I've shown you, metformin, SGLT2 inhibitors, and GLP-1 receptor agonists have other benefits like blood pressure reduction, lipid changes, cardiovascular disease modification, etc. are there for other oral agents because they don't just control glucose like insulin, they also control other things like metabolism, inflammation, and weight, etc. are controlled by oral agents. So there is always going to be a place for oral hypoglycemic agents. Whether we will use insulin as one of the first therapies in diabetes type 2 when oral therapy is available remains to be seen. But it's a therapy that will benefit. It will keep the beta cells functioning longer, but at the cost of an injection. That is why we don't give it as the very first drug for all type 2 diabetics.
Thank you, sir.
So is there a association between intensive therapy to target normal glucose levels between mortality due to high cardiovascular diseases as mentioned in Accord studies?
Yeah. So Accord is a study. So we have multiple diabetes control studies. So we have the UKPDS, which is the first study that had shown that myocardial infarction was decreased and all-cause mortality was decreased. The second generation of the glucose trials tried to bring down the glucose to 6 to 6.5 rather than 7 to show that patients with previous myocardial infarction will benefit with rapid and aggressive diabetes control. So those were Accord, Advance, and VADT, Veterans Affairs Diabetes Trial. In those three trials, the Advance study, which used glycoside modified release as its primary mechanism, showed that there was no further benefit in myocardial infarction by lowering glucose further than 7. But it also showed that kidney failure, etc., could be reversed by that mechanism, although myocardial infarction couldn't be prevented. Accord was much more aggressive, and there were people with hypoglycemia. So you must remember this was a cohort of patients who had previous myocardial infarction, and they had multiple complications. So when such a aggressive therapy was introduced in them, there was an increase in mortality. Only in that study it was shown. In the advanced study it was not shown. Therefore, what we've learned from that is that in patients with multiple comorbidities, you shouldn't bring down the glucose very, very aggressively. So you will see that recommendation reflected in this slide, where we say if there is advanced stage and multiple comorbidities, say MI, stroke, etc., the HbA1c is less stringent. It's 7 to 8 rather than in the Accord where the HbA1c was 6.5. So this slide set was created actually after that study, where we say the patients who will be able to have no hypo and have very good outcomes are these new onset diabetics, young age, well motivated, and with no other comorbidities. Whereas if they have multiple comorbidities, we now accept an HbA1c 7 to 8, unless we can do that without hypoglycemia. So it's now possible, not possible in the Accord era, where even in this patient with multiple comorbidities, to bring the glucose down to 6.5 without hypoglycemia. Now we can do it. As I showed you, there are 4 new group of agents can. They had to use insulin, thiazides, etc., which had much more side effects than hypoglycemia.
Thank you, sir.
Yeah. All right. So if there are no other questions, I'll give you just 30 seconds or 5 seconds to ask any other question. If nobody is interested in a question, let's stop it there. All right. So I don't see anyone coming forward to ask any questions. So let me stop there. So I've done these 2 lectures and I hope you will remember them and use them in your practice. Thank you.